Thank you so much for having me this morning. I'm really excited to be here. It's a pleasure. This morning I'm going to talk about a Wilms tumor. And I've selected this topic for a variety of reasons, but one reason in particular is that I think it is absolutely phenomenal, the advances that have been made in the care of Wilms tumor over the course of the last several decades. Truly, several decades ago, this illness was thought to be universally fatal and with a very dismal prognosis. And with today's therapies, greater than 90% of children have the 5-year survival rate is greater than 90% for all children. So it's really been quite a remarkable success. And it is generally regarded as a success story in the field of pediatric oncology. And largely the reasons are because of the application of multimodal therapy, using cooperative study trial groups to study children and see who's getting better outcomes based on what therapies. And of late, using molecular markers to identify which children are going to be more susceptible to disease relapse and require more intensive therapy. So one of the other, before I go any further, I have no conflicts to disclose. Okay. One of the other reasons I find Wilms particularly fascinating is because there are some very, very notable figures in the field of medical history that have been involved, and surgical history as well, that have been involved in the management of Wilms tumor. Depicted on the left is John Hunter. John Hunter is probably one of the first surgeon scientists. He was a British surgeon who really embraced the idea of scientific observation and basically pooling lots of different specimens in order to study them and determine what might be better treatment approaches. He was a very interesting character. He was known for having a very fiery temper, and apparently he died of a heart attack during an argument with a colleague. So note to self, be pleasant with your colleagues. We're all here to take care of the children. Anyway, so John Hunter, between, 1763 and 1793, collected a very large specimen of pediatric renal tumors. And he's among other specimens that he collected. And what you see depicted in the middle is a Wilms tumor. A Wilms tumor is a renal tumor. It is the most common renal tumor in children under the age of 15 and is the 4th most common cause of childhood cancer. And he was collecting these specimens, as you see, between, as I mentioned, the late 1760s to 1790s. So that tumor is split in half. You can see there it's a left kidney, actually, and there's a tumor emanating from the hilum of that left kidney. The Hunterian Museum, by the way, is located in London. It's very interesting and has just an enormous amount of specimens that this particular surgeon had collected. But really, Karl Max Wilms is the eponym for which Wilms tumor is actually named. And he also had an incredibly interesting career. He started out as a pathologist, collecting samples, including many renal tumors. And in fact, in 1899, he published a very famous monograph detailing his collection of many of these pediatric renal tumors, which were all Wilms tumors. And what's equally fascinating is he was very precocious in some of his hypotheses. In particular, even at that early time, he suspected that these tumors were arising from the embryonal tissue, which is pretty fascinating to have made to be postulating that, literally centuries ago. Also of note, I am a surgeon, and what's very interesting is Karl Max Wilms had a second career when he was past his pathology. He really entered pathology because he had an interest in surgery and he wanted to learn more about the tissue. So when he subsequently became a surgeon, he really acquired most of his notoriety for identifying that intestinal bowel obstruction, which had previously thought to be something that we could treat with medicines, was actually something that we could treat with surgical interventions. And again, pretty advanced for that time period. So what's very interesting is that during his life, he was a very famous surgeon who had this success from really identifying surgical therapy for intestinal bowel obstruction. But posthumously, obviously, he's much more well known for being the eponym for Wilms tumor. So I continue with some of the interesting history regarding this tumor by really introducing some of the very significant players in pediatric surgery, pediatric radiology, and of course pediatric cancer and chemotherapy in general. On the far left is William Ladd. He is the father of pediatric surgery. He had a very, very successful career in Boston, and he really completely dedicated himself after witnessing the results of a horrible explosion in Halifax and how it impacted the children there to taking care of the surgical problems that children have. Dr. Ladd and his successor, Dr. Gross, an equally famous pediatric surgeon, had a very significant impact with regard to Wilms tumor, was identifying that there were some surgical principles that should be followed in the resection to basically improve outcomes. Simply put, in the 30s, the survival rate for Wilms was about 15%. By the 40s, with the combination of Ladd and Gross, they had improved that to about 25%. What were they doing differently? They were doing a transperitoneal resection, giving a nice wide visualization. They were getting early control of the renal pedicle so as not to have significant blood loss, taking surrounding gerotous fascia as well to incorporate the lymphatic extensions, also with the hope to prevent relapse in the future. These are some of the significant surgical techniques that they had used to treat Wilms. But really, it's still, by the 40s, that's a very dismal prognosis, 25% survivors after 5 years. One of the first initial big steps, and the idea of treating this disease with a multimodal therapy, was an idea proposed by Gross and Edward Niehauser, who is the father of pediatric radiology, also in Boston. And what they did was they incorporated radiation therapy for the children. So this improved survival rates to about 45% by the 50s. But one of the major advances was made by Sidney Farber, depicted there on the right. And this was really quite phenomenal. So what he did was he added actinomycin D, which at the time was used as an antibiotic, to treat children with Wilms, and got pretty phenomenal results. Even by the late 60s, the survival rate for all comers, the 5-year survival, had improved from about 45% to upwards of 80%, approaching 90%, with the addition of the surgical techniques that have been earlier proposed, radiation, and most importantly, actually, or one of the more significant ones was the addition of actinomycin D. Sidney Farber had just an extraordinary career. It was really remarkable. He, again, father of chemotherapy. He dedicated his life also to the care of children, but his work impacted far beyond the scope of pediatrics. And beyond that, he's actually, he himself has an eponym. He's for Farber disease, a liposomal storage disease. He identified that because he also he was a pathologist. And then he's also very well known for having successfully acquired a lot of funding for cancer research. So really quite extraordinary. So Wilms tumor, or rather renal tumors in children, constitute one of the diagnostic groups of the International Classification of Childhood Cancers. They have a group unto themselves, and they constitute about 5 to 7% of childhood cancers. And there are many types of renal tumors in children that are depicted here, but far and away in the age group under 15, Wilms tumor is going to be the most common. The other ones that are listed there are pretty rare, but it's very important to be aware of them, particularly with the different therapy approaches that we do, and in particular because some of them, which I'll explain further momentarily, can have secondary tumors that need to be recognized early. So, included in the differential for a Wilms tumor would be a renal medullary carcinoma. That's depicted in the slide, the upper left part of the slide there. And these can be very large, multiloculated tumors. They can have early metastases. That arrow there is depicting hepatic metastasis, hepatic met. They, unfortunately, these are can be very, very dangerous tumors, and interestingly, they tend to strike children who have carry the sickle cell trait. B is a renal cell carcinoma. In the pediatric population, 15 years and older, a renal cell carcinoma is going to be more common than a Wilms tumor, so that we need to think about. These are highly variegated, you know, lots of different colors you can see in the gross specimen. They tend to be very well encapsulated. C depicts a rhabdoid tumor. Rhabdoid tumors also very, very malignant tumor. They tend to be the most common renal tumor of infancy. And they also strike children when they occur. They can frequently be associated with a primary cerebral tumor, a medulloblastoma. So that needs to be considered when evaluating a patient for a possible rhabdoid tumor. Congenital mesoblastic nephroma is listed there in D. That's also a tumor that can be seen in infancy. These can be very, very large. These are generally treated with surgical resection. And then finally, E is a clear cell sarcoma. And histopathologically, this is the tumor that's most likely going to be confused with Wilms tumor. You have these nests and cords of cells on H&E staining. These are also highly malignant tumors. They can be very frequently associated with bony metastases, and they can be very devastating. But these tumors would be included in the differential when we're talking about Wilms tumor. Of course, neuroblastoma always has to be entertained. And often we can discern between a Wilms tumor versus a neuroblastoma by imaging, CT imaging, and sometimes even ultrasound imaging. And what this slide here highlights is that some of the main findings we see, in particular, this right here is the so-called claw sign. A Wilms tumor emanates from the kidney itself. So what it does is it doesn't displace or distort the shape of the appearance. It basically grows from the kidney, so you can barely recognize the kidney at all. And this is the so-called claw sign that you can see here, where the renal tissue is sort of splayed out here. And doesn't really look recognizable as a kidney. Unlike on the right side, where in neuroblastoma, the external compression tends to push and indent the kidney. Other findings that you can see on CT and even sometimes ultrasound, you can see calcifications associated with neuroblastoma. Neuroblastomas tend to cross the midline, where Wilms tumors don't, but they can. The other particular finding is neuroblastomas tend to encase vascular structures. With surgically, that can make it, they can be very, very challenging to manage. Whereas Wilms tumors tend to be a lot more encapsulated. Although they can be big and they can be very fragile and be very challenging, they don't have that property of really that invasiveness in the encasing tumors. Wilms tumor, what they can do, in lieu of encasing, what they can do is actually grow into some of the vasculature. So it's not, Wilms tumors can grow into the cava and the hepatic veins and things like that, which can obviously make for a very challenging resection. So, as I mentioned, 15 is really the dividing point, if you will, and under 15 you entertain Wilms tumor. Over 15 for a renal tumor, you're entertaining primarily renal cell carcinoma. But among those younger children, basically 95% of renal tumors are likely going to be a Wilms tumor. It's a very rare tumor. We're seeing 500 approximately of these tumors per year, with an annual incidence about 8 cases per million children. And the risk varies by ethnicity. African American children are at the highest risk. Asian children are at less risk relative to African American children, Caucasian children. Clinically, the presentation is really interesting because even though these tumors, as I mentioned, can be large, they can enter into vascular structures, it is not uncommon for children to present with a primary caregiver, such as a grandmother or even mother, who's noticed that they happen and the belly just seems a little bit bigger, but there are not a lot of other constitutional symptoms going on. So essentially, a lot of these children present with a painless abdominal mass. I'm certainly involved in the care of several children whose, in particular, grandmother noticed during a bath that the abdomen was very large and brought in for evaluation. They can, of course, have symptoms including malaise, pain, even gross hematuria. Pain would make you certainly worry for the possibility of, sometimes bony metastases can be associated with that, so you really would enter, perhaps it is a neuroblastoma versus a Wilms. Hematuria is concerning for extension into the renal pelvis. That being said, most children, going back to that previous slide regarding distinguishing between neuroblastoma versus Wilms, Generally, children presenting with neuroblastoma look ill and would most likely have malaise symptoms and that sort of thing, whereas Wilms tumor children do not have that. Rarely in Wilms tumor, due to renin hyperactivity, you can get hypertension. One really critical thing with Wilms is that 1 in 4 of these children will have an associated congenital syndrome. So it is very important to be looking for some of the other findings that would suggest that, because if that's the case, there are obviously other things that we need to monitor them for. So some of these associated congenital syndromes include what's depicted there. In the upper left, you have the Weger syndrome associated with Wilms, aniridia, genitourinary anomalies, and intellectual disabilities. Although some of the children don't have intellectual disabilities, there can be variant forms. Hemihypertrophy we can see as well. It's the left lower extremity on that child that you can see is larger relative to the right. Beckwith-Wiedemann syndrome, a whole array of anomalies. You can have enlarged organs, macroglycia, an omphalocele. You can have a hyperinsulinemia, hypoglycemia, which can be very life-threatening. And these children can also have Wilms. Interestingly, the combination of a child with Beckwith-Wiedemann who also is presenting with hypertrophy is an absolute concerning clinical presentation for a potential Wilms tumors. About 40% of those children will go on to have a Wilms tumor. Simpson-Galabi-Behemel syndrome is an overgrowth syndrome that can be associated with Wilms tumors as well. One not depicted here, something I've been involved in the management as well, Dennis-Drash syndrome. Can be associated with nephropathy, renal failure, disorders of sexual differentiation. These children can also have Wilms tumors. And the point here is not only if you have a child that has a Wilms tumor and you want to make sure that you're not missing an underlying anomaly, or an underlying syndrome rather, but vice versa, if you are managing a child with a syndrome, they need to be on a very regimented schedule to be getting serial ultrasounds. Typically it's variable, but typically up until about the age of 8 to make sure that they don't develop a Wilms tumor, and if they do, to make sure that it's captured as early as possible. So what's very interesting about Wilms tumor and the association with these congenital anomalies is that it's had an enormous impact on our ability to start to understand this tumor at the molecular level. What I mean by that is most people probably remember from medical school Alfred Knudsen. Knudsen's famous for the 2-hit hypothesis. Well, he studied the idea that you required 2 hits in order to get 2 mutations, if you will, in order to develop a cancer. And what he studied, the bulk of his work was actually done in retinoblastoma, but part of his work was incidentally done in children who had aniridia and developed Wilms tumor. And what made the ability to do this is that there was this recognition that children were getting these tumors and also had these associated congenital anomalies that sometimes seemed like very disparate. So the thought was that, well, perhaps that there is a fairly large disruption of the chromosome, and that if we study all the children that phenotypically are alike who have these tumors, we can identify this large disruption. So that was sort of the idea behind, and what really, very simply put, trying to identify where some of these chromosomal anomalies were. To date, many have been identified. 2 are depicted there, chromosome 11, WT1, WT2. That being said, the genetics of Wilms, extremely complicated. It's estimated about 20% of children who have Wilms tumor can be explained by a chromosomal anomaly depicted here, but the remainder we still don't really understand why they're developing. So at the molecular level, there's millions of questions obviously to be answered. At the level of the tissue, what we know is that children who have Wilms tumor seem to have what are called these nephrogenic rests, or this progenitor renal tissue that has the ability to develop into other tissue. Now, it's not uncommon to have this. About 1% of infants are born with nephrogenic rest, and most infants will go on, and this will resolve, not become an issue. But some of the infants will go on, and it will, and as they grow later into life, will go on to become a Wilms tumor. So what you have depicted here is some of the pathology demonstrating I'm sorry, there we go. So normal tissue, a nephrogenic rest that I mentioned, and then in close association, a developing Wilms tumor. So if we go in higher magnification, what exactly do we see in the Wilms tumor tissue? What we're seeing is a triphasic appearance, meaning we have blastomal tissue, which is that progenitor tissue I mentioned. We have stromal tissue, which can be it can be cartilage, it can be fat, it's very disrupted. And then we have epithelial tissue that's very distorted as well, that can have these abortive tubules and abortive glomeruli and just looks grossly abnormal. And that triphasic appearance is very characteristic on H&E staining what Wilms tumor looks like. So this is one of the earlier proposals of the model for tumorigenesis, trying to incorporate what we know about nephrogenic rest, as well as some of the sort of nuts and hypothesis and the requirement of several chromosomal hits, so to speak, in order to develop a tumor, and also considering some of what we know about the molecular markers that put you at higher risk. So as I mentioned, some children are born with these nephrogenic rests, and they can resolve and they can go on to be a normal development, never to develop a tumor. But then some children who may be predisposed with existing mutations, and that might perhaps lead to the persistence of these nephrogenic rests. And then some other hit, or some that remains to be seen, chromosomal disruption might occur that results in Wilms tumor. What we have been able to identify, and this is carried on through actually multiple trials of Newitz, which I'll discuss in a lot of detail in a second, is that there are certain markers, but there's a certain tissue type that's particularly worrisome for relapse and basically associated with a high morbidity and mortality in Wilms, and that is anaplasia. It's this idea that on H&E staining, you're seeing these polyploid nuclear matter, and it looks grossly abnormal, and this is very worrisome. These children are at a very high risk and are generally administered higher and stronger, more potent regimens of chemotherapy and radiation. But to date now, we've identified P53 certainly, and loss of heterozygosity of some of the other loci have been identified and associated with anaplasia. So grossly on pathology, these are well encapsulated. Variegated means they have different colors associated with them. They're pretty vascular, and they can have extension, as I mentioned, into different, into the pelvis, into the cava, into different surrounding vascular structures. So with a child presenting with an abdominal mass that perhaps is concerning for a Wilms tumor because you're suspicious it might be a renal mass, perhaps there's already been an ultrasound, something like that, one of the, obviously a battery of tests is going to be ordered. A CBC, of course, chemistries, knowing the baseline creatinine to get an idea of how much the GFR has been affected. Coags, of course, there is an acquired von Willebrand's condition that you can get associated with Wilms. So that's something you make sure there's no associated coagulopathy, and as well as LFTs if there's concern for possible. At this point, if you don't know what the tumor is, it's always important to have LFTs because that could be suspicious for metastases. Urinalysis can be helpful as well. Hematuria can apply an extension in the renal pelvis, as previously mentioned. Proteinuria, that's actually frequently seen in Dennis-Rash syndrome. And finally, urine catecholamines, and this again goes back when you're in the early stages evaluating the children, you're really trying to discern, could it be neuroblastoma, because that's a very common intra-abdominal tumor in children too. Could it be neuroblastoma versus a Wilms? Urine catecholamines can be very helpful to discern between the two. And then we move on to imaging. There are some really critical things that imaging is trying to help us identify, and some of the main questions that you want to answer is you want to find out, does the child have a solitary kidney, congenitally have a solitary kidney, because that's very important in terms of how you're going to approach the management. Are you dealing with a tumor that is bilateral? And I'll discuss that in detail, because that's obviously, treating the child's tumor and having a successful outcome should also mean that the child still has renal function and is not going to be reliant on dialysis and awaiting a transplant. And then finally, vascular invasion is very important as well, because that can really dictate the degree of difficulty with the resection and how aggressive you want to be with preoperative treatment before you move on to resection. The abdominal plain films can be very helpful. Mass effect with displacement of viscera. Calcification can imply a neuroblastoma. I've been involved in the past in the care of a child that's very interesting. He was getting worked up for a period of time for for constipation, and an enema was ordered into the course of this workup. And on the enema, you could see this pretty obvious displacement of the distal colon from what looked like an extrinsic mass. So subsequent to that, he went to have the intra-abdominal ultrasound, identifying the mass was the kidney was the origin of the mass in that particular child. Assessing patency of the renal vein and cava, as I mentioned previously. And then finally moving on to more advanced imaging, including abdominal CT and a thoracic CT, because you can absolutely have chest extension of the tumors. And these images can be, these CT images can be very valuable. They can, again, as I mentioned, discern between a Wilms versus neuroblastoma. But importantly, they can give you an idea of the extent of the tumor. They can answer some of those questions. Does the child have a single tumor? Is there contralateral involvement? As far as metastatic involvement, it's generally viewed that these CT imaging is not particularly a great modality to do that. In fact, probably the best modality is operative exploration. The management of Wilms tumor has been an incredible process that has involved an incredible collaboration between pediatricians and pathologists and oncologists and radiologists. And that has been done through the creation of these cooperative study groups. That because it's a rare tumor, in 1969, a lot of the groups that were taking care of children recognized that they needed to pool all their data together, study these children, put them on study protocols, determine what their outcomes are, and then we could take the very best care of these children and the children in the future. And that was sort of the premise behind the formation of the National Wilms Tumor Study Group. So there were 5 major clinical trials done. The first 4 were randomized, and the 5th was really investigating what are the molecular markers that I alluded to earlier that are under the umbrella of the National Wilms Tumor Study Group. And to date, we're still going back to that data and exploring really mining that data to find more information. In 2001, what happened was some of the additional oncology groups, pediatric oncology groups, pulled together with the Newitz group to create the Children's Oncology Group. And so today, the Children's Oncology Group is really the foremost expert on pediatric oncology, and goes on to continue to have clinical trials to study where the best outcomes for children, and also have basically have a risk stratified regimen for treating children based on how concerning their initial presentation are, with the idea that we maximize therapy but we minimize risk. Now that the Newitz and the COG group applies to children who American children and children in Canada. In Europe, there's a very different approach done. The approach in Europe has been dictated by the International Society of Pediatric Oncology, and interestingly, both study groups have had excellent outcomes, but they have a very different approach. What I mean by that is, for the American group, the COG approach is that surgery up front. Most children undergo surgery up front, get an evaluation, determine stage, and then subsequently go on their therapy. What's different in Europe is that what they do is they do chemotherapy up front. And chemotherapy is administered for a period of either 4 or 6 weeks, and then the children subsequently undergo surgical resection and then continue on their therapy. So it's fascinating that there's 2 completely different approaches, and yet they both have excellent outcomes. So in other words, the pre-therapy, if you will, Newitz or COG trial, this is the surgery upfront approach. And basically, the staging system is depicted there. One of the key between stage 2 and stage 3 is where you have a tumor that's relatively localized to one that has become spread to surrounding tissue. Stage 5 tumor is a very interesting and very in a dilemma, if you will. Stage 5 is when you have bilateral involvement, and there's been a pretty significant shift in the management of these children based on some of the outcomes from the aforementioned trials. And I'm going to elaborate on that further, but briefly what I mean is prior to, of late, what we and this has actually been ongoing now for about several years, but basically these children used to undergo biopsy of each site and subsequent resection. And what was unfortunate is that they were doing well from a cancer standpoint, but most of the children were ending up with significant renal impairment and renal failure. Because they either had a bilateral nephrectomy or they had such extensive tissue loss that they had no longer had renal function and were then awaiting transplants. So in other words, the American system sort of adopted what one might view as more of the European approach. These children currently get preoperative chemotherapy to shrink tumors bilaterally with the hope that you can go on in the future and do nephron-sparing surgery, so you can spare the renal tissue, spare the child the possibility of requiring dialysis. The PSYOP staging system is not dramatically different, but it's also anatomical, and you can see what's listed there is it's pretty similar, but with stage 1, the tumor is fully resected, limited to the kidney, so that's very early on, whereas stage 5, again, is bilateral renal involvement. And generally, again, the European approach is that children are administered either 4 or 6 weeks of therapy prior to resection. And these are the treatment regimens here. The mainstay of treatment for vincristine, actinomycin D, doxorubicin, and usually around stage 3 is when the incorporation of, you start considering addition of radiation. There's a lot of modifications. This is a very simplistic version. What I mean by that is there are those markers, the molecular markers are becoming really, really important for identifying children who are at very high risk for relapse, and therefore those children are assigned higher and generally more toxic therapies in order to avoid potential relapse. So this is the stage 5 that I was referring to earlier. About 7% of children who are presenting with Wilms will have a bilateral tumor. As mentioned, the previous protocol was aggressive. It was biopsy both kidneys, determine the stage, treat according to the highest stage, and then and proceed with surgical resection. But today, the current treatment protocol is intensive chemotherapy to shrink the tumors with the hope of nephron-sparing surgery. And this, the chemotherapy is going to be monitored by serial scans. So if the concern is that there's not adequate shrinkage, sometimes the chemotherapy is extended. If there's a concern that there's no response at all to chemo, then biopsy might occur in order to determine if there's an anaplastic component. So it's interesting to compare these two really different modalities that happen to both have excellent outcomes. So which could potentially allow for the use of chemotherapy for benign disease? Well, because the European approach is chemotherapy up front without actually having a tissue diagnosis, it would be that one. Potentially yield inaccurate tumor staging, that's also possibly the European one. The most accurate tumor staging is probably intraoperative. As I mentioned earlier, our CAT scanning is a little limited with allowing for lymphatic involvement, identifying lymphatic involvement. Possibly allow for a mismanagement of malignant tumor. Well, it's also potentially PSYOP. As I mentioned, sometimes it can be challenging to discern between you could theoretically have a nephroblastoma, which is a high level of these nephrogenic rests that I was speaking of earlier that could look like a tumor, and those wouldn't necessarily be treated with chemo, but if you do the European chemo upfront approach, and they would do that when ultimately you get your tissue and you realize you're potentially treating the wrong thing. Possibly reduce operative tumor rupture rate, PSYOP. It's when there are tumors that are crossing midline, very large, lots of extension. These tumors are really fragile. They can rupture easily. Once tumors ruptured, you've automatically, that's considered you've advanced them already to a stage 3. So there's absolutely advantage on some tumors that are deemed very large and worrisome for their resectability to administer pre-op chemo. So that is arguably a benefit of the PSYOP approach. But ultimately, the point is that both of these study groups have been very successfully decreasing the toxic therapy needed to promote long-term survival in these children. So what I've listed here is that there are countless conclusions from the Nowitz and the COG study trials. Some of the interesting ones I've depicted here. This is one of the earlier ones is trying to eliminate the need for radiation. Generally speaking, it used to be thought that children under 2 did, for the most part, did better than children that were older. That does depend on histology. And now that both treatment regimens have actually become quite good for no matter what stage, that's sort of not been as strong as of a prognostic indicator age. The NUITS-2 introduction of doxorubicin to increase the relapse-free survival rate. Cyclophosphamide was studied at one point. That's no longer, my understanding, incorporated into the management. And then duration of chemotherapy, that's also studied. But really, some of the latest trends are to evaluate, to really hone in on the molecular markers and identify which of these characteristics of the genome of these kids are really either resulting in anaplasia, worrisome for anaplasia, worrisome for relapse, worrisome for survival. And loss of heterozygosity, particularly 1p and 16q, has been identified as well in particular. That's depicted there on the right. These Kaplan-Meier curves are showing that basically relapse and survival are worse with the loss of heterozygosity when that's identified on pathology. By far, as mentioned, prognostic factors, histology, in particular anaplasia, is the most worrisome. As far stage is a prognostic indicator, genetic markers, as I mentioned, age not as much, but histology is probably one of the most important. Generally speaking, with favorable histology, the outcomes are very good. You can see there, even with stage 4, event-free survival, overall survival, 80 to 90%. You can see how dramatically these numbers change when you're talking about anaplasia. So it is imperative that we understand what is behind anaplasia. How do we recognize the kids that are likely going to develop anaplasia so we can treat them early and aggressively? So one interesting thing as well that's changed a little bit. Initially, there was the thought that children who were very young, under age of 2, in fact mostly infants, who had very small tumors, like less than 550 grams, might do well with just surgical resection alone. And that is, that could be good, but the concern there is that there are still some children with those characteristics that I described that will have anaplasia or concern for anaplasia on their histology. So it is a higher risk protocol in order to do that. So currently I do not believe that's advocated. Some of the operative principles to remark on again, and this goes all the way back to William Ladd, like and Gross, when they talked about getting really wide exposure. Previously they've been approaching these tumors with a retroperitoneal approach. We approach these tumors with a transperitoneal approach, so you get a really wide exposure. You don't want to compromise the potential to rupture a tumor to get a smaller scar. The goal is survival of the child, avoiding relapses. Aesthetics is always a consideration in my job, but I think you have to prioritize. So we make usually you can make a thoracoabdominal incision, but generally transperitoneal supraumbilical incision. You can see there in the picture B that these tumors can really distort everything. They can be very large. The colon is sort of off to the side, but and they can have these very large vessels associated. And then in C, you can see that you can have this extension of the tumor that you want to identify that before. While you're operating, you want to have that identified, and not because you don't want to risk disrupting that tumor thrombus and throwing tumor systemically. So the main goal surgically is you want to get a nice wide exposure. You want to identify the extent of disease. You do not want to rupture the tumor. You want to identify intravascular invasion. All of those principles important to prevent recurrence. This is a mass there you can see depicted. Again, the point of this is really just emphasizing you can have a lot of distortion. And this is critical too, because when not only can you have a distortion of the obvious, the colon can be in a slightly altered location, stomach can be a little bit displaced. It's very important for the vascular structures. You can have the contralateral renal vein displaced, and that you want to be aware of, because you want to take great care not to injure surrounding structures, especially when your hope is to perform a unilateral radical nephrectomy. Okay, so indications, and I showed you some pictures there of some very large tumors. There are indications on imaging that we'd see preoperatively that you would be more inclined to proceed with doing a chemo upfront approach and delaying surgery to get some potential shrinkage of the tumor, have better control, and have less risk of a rupture. Those would be very large tumors with intravascular extension, tumors maybe that cross midline, or if you have solitary kidney or the bilateral tumors that we discussed. And then additionally, if you had respiratory distress from extensive pulmonary metastases, that's very worrisome for a child tolerating a very significant operation if you have some pretty significant underlying pulmonary disease. The surgical complications absolutely exist. You can have what are listed there. This was Nowit's trial 4, where they studied the overall complication rate exceeds about 12%. From intestinal obstruction to significant hemorrhage, wound infection, to extensive vascular injury. And then the factors are probably listed there, factors that would contribute to more likely occurrence of these would include things like a really advanced tumor, the existence of intravascular extension, especially if it's not identified until later in the course of the operation. Resection of other organs is not advocated. That is, if the tumor is so extensive that there might be a requirement of resection of other organs, generally I would think the chemo upfront approach would be advocated. So where are we going with the future inquiries? It's very, very, the trend very much seems to be molecular genetics and identifying these molecular markers. In particular, really characterizing anaplasia and what is happening at the molecular level that leads to that. It's pretty profound that, the survival rates of these children are very good, but what they were looking at in some of the earlier Nowit's trials is that although there were only 10% of the children that were not surviving the Wilms tumor, upwards of 60% of those children had anaplasia, really defining it as one of the most worrisome things about the tumor. And then continuing to do what the original members of Nowit's and what COG members do is we want to maximize our therapy but minimize toxicity. And that is the goal likewise the goal of the PSYOP trial. So in summary, we've had some remarkable improvement in the outcomes, largely because of these enormously collaborative groups, Nowit's and PSYOP and COG, that have really studied these children to get their best outcome. The addition of the multimodal therapy has been instrumental, having the addition of radiation, the addition of chemotherapy way back in the 1960s as introduced by Farber. Those are phenomenal and have made an enormous impact. Recognizing that there are histopathological findings that are very concerning for recurrence. And then also recognizing, which I did not really emphasize, but that long-term follow-up is really important in these children, especially if they're genetically predisposed to develop the tumor. So just to close here, I think it's pretty amazing that a tumor that impacts about 500 children a year has resulted in a tremendous insight into the molecular genetics of cancer, as seen with Knutson's hypothesis, and the idea of the absolute essential value of multimodal therapy from Farber's work and Niehauser's work back in the 60s, and then what the impressive progress that we can gain when we work together, and that when we pool our collective insight, as seen by the work of the collaborative oncology groups to get the best outcomes for children. And all of this work was done with a pediatric tumor, so impacting and having benefits just far beyond the scope of pediatrics. So I think that makes Wilms tumor a pretty fascinating topic.